I'm going to present a study on the prevalence of ECG anomalies in young individuals and assess the implications for a nationwide screening program in the general population in the United Kingdom. So data from the 35-year Italian experience of pre-participation screening incorporating the 12-lead ECG with clinical history and physical examination has been shown to significantly reduce this incidence of sudden cardiac death amongst competitive athletes. Based on this evidence, learned scientific organisations and sporting governing bodies have endorsed the routine use of the 12-lead ECG in screening of competitive athletes. In 2010, the European Society of Cardiology published guidelines relating to recommendations for the interpretation of the 12-lead ECG in athletes specifically. This consensus report divided ECGs into Group 1 and Group 2 ECG patterns. Group 1 ECG patterns are considered to be common and training related, whereas Group 2 ECG patterns are considered to be uncommon and training unrelated. And the ECG consensus report recommends that when such Group 2 ECG patterns are identified, it should warrant further evaluation for conditions associated with sudden cardiac death. Further data from Italy has also suggested that regular physical exercise on a background of a quiescent cardiovascular abnormality infers a threefold greater risk of sudden cardiac death in competitive athletes compared to their non-athletic counterparts. However, the majority of sudden cardiac deaths actually occur in the general population of non-athletic individuals. In most countries, including the United Kingdom, screening in the general population is confined only to those individuals with symptoms of a cardiovascular nature or those individuals with a family history of premature cardiac disease or sudden cardiac death. There's also a paucity of data relating to the prevalence and significance of ECG changes in the general population. So the aims of this current study were to establish the prevalence of Group 1 and in particular Group 2 ECG patterns in a large cohort of young individuals and to try and evaluate the potential implications for a nationwide screening program in the general population using current ESC criteria from the 2010 consensus report. So we evaluated almost 8,000 non-athletic individuals and just over 4,000 athletic individuals aged 14 to 35 years over a 4-year period. The evaluation consisted of a health questionnaire, particularly relating to symptoms of a cardiovascular nature, past medical history and drug history, and family history of premature cardiac disease or sudden cardiac death. A physical examination and a 12-lead ECG was also carried out. A non-athlete was defined as an individual not involved in regular, organised, competitive team or individual sport and included sedentary individuals and those exercising recreationally. Athletes, on the other hand, were defined as individuals competing in organised sport, on either a team or individual basis, at regional, national or international level, with a high premium on athletic achievement and excellence. ECGs were analysed for specific Group 1 and Group 2 patterns as described in the ESC consensus report. Transthoracic echocardiography was also performed, but was reserved for those non-athletic individuals with Group 2 ECG patterns suggesting cardiomyopathy or structural cardiac abnormality. So firstly, comparison of the demographic data between the two study cohorts. The non-athletic population was younger and included fewer males and more white individuals by ethnicity. The non-athlete cohort also included individuals with a lower body surface area, demonstrated a higher resting systolic blood pressure and higher resting heart rate, as perhaps you'd expect in non-athletic individuals compared to athletes. The pie charts presented here demonstrate the prevalence of Group 1 and Group 2 ECG patterns. You can see that there's a high prevalence of Group 2 ECG patterns either in isolation or in conjunction with Group 1 ECG patterns in both non-athletes and athletes. This occurred in 21.8% of non-athletes and 33% of athletes. And bearing in mind, by definition from the ESC consensus report, these would be the proportion of individuals that should be for further evaluation to rule out conditions associated with sudden cardiac death. Looking specifically at certain Group 2 ECG patterns, I've highlighted in blue squares those Group 2 ECG patterns which were more common in the non-athlete cohort, and in red squares, those Group 2 ECG patterns which were more common in the athlete cohort. We can see that T-wave inversions, particularly in the anterior leads, were more common in athletes, However, other ECG parameters in the group 2 category that are associated with cardiomyopathy, such as ST segment depression, pathological Q waves, and bundle branch block, were rare in both groups. Other ECG parameters suggesting structural cardiac changes, including left atrial enlargement, right atrial enlargement, and right ventricular hypertrophy, were more common in the athlete cohort. Group 2 ECG criteria suggesting ion channel disease were common in both groups. A long QT interval was more common in the non-athlete cohort, and a short QT interval was more common in the athlete cohort. Ventricular pre-excitation and Brugada-like early repolarization was rare in both groups. The histogram here demonstrates an important point, that in the majority of cases, group 2 ECG patterns actually occurred in isolation. Only 3% of non-athletes and 8% of athletes demonstrated more than one group 2 ECG abnormality on a given ECG. If we analyze specific group 2 ECG patterns as a proportion of the total number of group 2 ECG patterns, we can see a number of things. In the non-athlete cohort, 11% demonstrated T-wave inversion as a proportion of the total number of group 2 ECG patterns. Almost a third of the cohort in the non-athlete cohort demonstrated voltage criteria for left or right atrial enlargement, voltage criteria for right ventricular hypertrophy, or left or right axis deviation also. However, by far the most common group 2 ECG abnormality was that of a prolonged or shortened QT interval, which accounted for over 50% of the non-athletic cohort. And similar trends can actually be seen in the athlete cohort as well. We performed a multivariate analysis also to assess the independent association of demographic factors such as age, gender, ethnicity, and body surface area with group 2 ECG patterns. In the non-athlete cohort specifically, male gender and black ethnicity demonstrated the strongest association with a group 2 ECG pattern. So, as I've already mentioned, 21.8% of non-athletes and 33% of athletes demonstrated a group 2 ECG pattern requiring further evaluation. Broadly speaking, group 2 ECG patterns can be divided into those suggesting structural cardiac abnormalities, including cardiomyopathy, and those suggesting electrical cardiac abnormalities, including ion channel diseases. We can see that in our non-athlete cohort, 10.1% demonstrated group 2 ECG changes suggesting structural cardiac abnormalities or cardiomyopathy, whereas 13.5% in the non-athlete cohort demonstrated group 2 ECG changes suggesting electrocardiac abnormalities or ion channel disease. Looking specifically at those 10.1% of non-athletic individuals with group 2 ECG changes suggesting structural abnormalities or cardiomyopathy, actually a normal echocardiogram was identified in the vast majority. Incidental findings of cardiac dimensions exceeding predicted upper limits occurred in 10%, and 4% demonstrated minor congenital abnormalities, including patent foramen ovale, atrial septal defects, and mitral valve prolapse, to name a few. Interestingly, only 2% of this cohort of individuals demonstrated echocardiographic features consistent with morphologically mild cardiomyopathy. Of particular relevance, however, is that all of the individuals in this group did exhibit T-wave inversion on their ECG, either in isolation or in conjunction with other group 2 ECG patterns. Also of relevance, none of the individuals in this group demonstrated ECG evidence of voltage criteria for atrial enlargement or right ventricular hypertrophy or axis deviation. So the results demonstrate a number of key areas for discussion. First of all, the study reveals a higher than expected prevalence of group 2 ECG abnormalities in a fifth of non-athletes and a third of athletes. Group 2 ECG patterns suggesting cardiomyopathy occurred in 10.1% of non-athletic individuals, but only a very small proportion actually had echo features consistent with cardiomyopathy on further evaluation. T-wave inversions were actually rare in non-athletes, occurring in 2.8%, but their presence occurred in all individuals with echo features suggesting cardiomyopathy. Whilst this suggests that the presence of T-wave inversions raises the possibility of cardiomyopathy, we must put this in the context of individual demographics. It is established that T-wave inversion in the anterior ECG leads V1 to V4 is considered a normal variant in adolescent individuals and those of Afro-Caribbean ethnicity. The data also suggested that voltage criteria for left or right atrial enlargement, right ventricular hypertrophy, and axis deviation did not predict cardiomyopathy. Our data also showed a high prevalence of a long QT interval occurring in 6.5% of all non-athletic individuals. This likely creates an overlap zone with a high frequency of false positives and difficulty deciphering whether an individual truly has a long QT syndrome as opposed to a long QT interval. The data also showed a high prevalence of individuals with a short QT interval, occurring in 6.9% of non-athletes. And again, this likely represents a significant overestimate of the proportion of individuals with a short QT syndrome, given the incredible rarity of this ion channel disease in the general population. And of course, these intervals do not take into account family history of sudden death or QT syndromes or symptoms. Previous studies have suggested, in large population-based studies, that a QT interval outside the recommended cutoffs proposed by the ESC can occur in up to 15% of the general population. Highlighted in this diagram, the green boxes show the cutoffs applied from the ESC criteria and show the prevalences we reported in our cohort. So 6.5% had a prolonged QT interval and 6.9% had a shortened QT interval based on the ESC criteria. However, the 36th Bethesda Conference and the recently published Seattle criteria have proposed refined criteria for cutoffs for long and short QT intervals, as demonstrated in the purple boxes here. When these criteria are applied to our non-athlete cohort, the prevalence falls to 1.2% for a prolonged QT interval and 0 for a short QT interval. Some authors have also reported that a QT interval of over 500 milliseconds would be diagnostic of long QT syndrome. And in our population of non-athletes, that equates to 0.2%. Of course, the study has a number of important limitations. Firstly, transthoracic echocardiography was limited to just those non-athletes with group 2 ECG patterns suggesting cardiomyopathy or structural cardiac abnormalities. Therefore, we cannot calculate the true sensitivity and specificity for detecting structural cardiac disease. We also did not report the results for further evaluation in the form of 24-hour Holter monitoring, exercise stress testing, or familial evaluation in those individuals with a long or short QT interval, and therefore we cannot comment on the true significance of these findings. However, we did report such a high prevalence of long and short QT intervals, which are several hundredfold higher than the reported incidence of long and short QT syndrome in the general population, that it would be fair to report that this is a gross overestimate of the actual incidence of these conditions in the general population. An important point about the non-athletic population as well is that we define them as individuals not participating in formal competition. However, over 30% did exercise recreationally for more than 4 hours per week, and only 17% were truly sedentary individuals. You could argue that, as by definition, some of our non-athlete cohort were in fact athletes. However, this does represent a true, unselected group of young individuals that any general population screening program is likely to encounter. So in conclusion, our studies suggest that 1 in 5 of young individuals would require further evaluation if ECG screening was implemented in its current form using current ESC criteria. This has significant implications on the feasibility of ECG screening, given the low incidence of sudden cardiac death and the substantial population of people aged between 14 and 35, which is 16.5 million in the United Kingdom at present. This also has important cost-effectiveness implications, as many group 2 ECG patterns, particularly in isolation, are non-specific and warrant more detailed and costly further evaluation before a cardiac diagnosis can be reached. There is, of course, a significant detrimental effect of false positive results, leading to unnecessary further investigations and also psychological stress on the individuals concerned and their family members. And it's important to bear in mind that this situation would be worse in cosmopolitan societies such as the United Kingdom and even the United States, where there's a high population of black individuals. So for the ECG to be utilized as a screening tool in the general population for conditions associated with sudden cardiac death would require refinement of current Group 2 ECG criteria, as proposed in the table presented here. We've categorized Group 2 ECG changes into those suggestive of structural cardiac abnormalities and cardiomyopathy, and those suggestive of electrocardiac abnormalities and ion channel disease. When these refined criteria are applied to our non-athletic cohort, the proportion of individuals requiring further evaluation falls from 21.8% to 3.8%. Thank you very much for your time, and I welcome any questions.